So the second introduction to cytopathology, to then focus on my favorite, my passion, which is finding the aspiration biopsy. What's fine needle? It's 20 to 27 gauge. Diameter is 0.7 to 0.4 millimeter, which is different from needle core biopsy. Needle core biopsy is 12 to 16 gauge. So it's much bigger. Fine. Hi, David. So fine needle could penetrate through a gastric wall without leaking gastric acid, could penetrate through abdominal aorta, everything will snap back. The key is this, how fine the needle is. 20 to 20 gauge is smaller than surgical suture. And then you could do a CT-guided FNA using 25 gauge spinal needle. And that's what they use at Park Avenue Radiology. It's so easy. And 27 gauge is acupuncture. And so for thyroid, use 27 gauge. And other institutions may use 23 gauge. It's still considered fine needle. But the needle core biopsy, it's a lot more invasive. If you use this needle core biopsy, penetrate through gastric wall, you start leaking and go through aorta, it will burst. So because it's fine, it's much, you have to use totally different approach to make diagnosis. And I always use the triple test. First, clinical. Second, radiological. Radiology give me gross diagnosis, the size of location. If I see a healthy patient with a big nodule, and I know this nodule is not aggressive, so you think in accordance. Then the third is cytology. And then it's very crucial to make good smear. And in my opinion, Sweden, Karolinska, to make the major contribution in perfecting smearing technique, especially Dr. Lohaugen, who travel all over the world, teach people how to make a perfect smear. A perfect smear is an oval shape with a head, body, and tail. And then if you done it right, the tissue fragment concentrate in the midline, and the periphery are, you could test the cell junction, cells will separate. And then from 1995 to 2010, I was invited to Park Avenue Radiologists, and they have put this, they specially designed a very big ultrasound room and then very wide cabinet. So whenever it's finished, they just put the rack and hide it in the cabinet and push all the supplied microscope back to a storage room, so everything disappeared. And I requested at that time Cornell to give me a old, but it's double-headed AO scope. So when I was at NYU, always bring a resident, rotating resident, so he could look at only, or she could look at on the other side. And then here's the diff quick, the 3 stains, and then the normal saline, alcohol, and water. And then with that, and then you have Permon, everything. Then I'm all set. I could diagnose anything. And I told Dr. Messina initially, I have a lot of atypical suspicious, but as I gain experience, it'll be less. Because when I was invited, I was only 3 years out of fellowship training, but I was much older experience. I have my life experience. So that's what I use, diff quick, ultra-fast PAP. And with that, I could diagnose or at least triage anything with confidence. And what's the clues during on-site assessment? Diff quick stain, which is less than a minute, it gives me nuclear volume because everybody's red blood cells 7 micron. I can measure nuclear volume. Background substance, whether it's colloid, mucin, or serous, or glycogen. I could tell glycogen by Tygor pattern. And then most important is medical matrix. It means collagen. It's a mesenchymal lesion. So it could be a chondroid, it could be sarcoma or sarcomatoid carcinoma. And negative images are very important, looking for vacuoles, MAI. So you have to, when you have diff quick stain, use these rather than use, the usual, what you're used to. You try to look for different things. And then diff quick is very important for lymphoglandular body to determine lymphocyte. And diff quick could, you could see eosinophils, plasma cells. In pap stain, you don't see eosinophil. There's no eosin. And then the plasma cells, you don't recognize it. They look like lymphocytes. And then ultrafast pap stain, less than 2 minutes. It's look for architectural feature, whether it's papilla, solid follicles, because in diff quick stain, the papilla are so flat and dry on the slide, you don't recognize it's a papilla until it's rehydrated, like this flattened balloon rise up, and then the papilla becomes very conspicuous. Also, of course, I use ultrafast for nuclear features. The shape, whether it's oval, it's round, whether chromation, whether the nucleus is prominent or nucleus inclusion, etc. Also, it's for cytoplasmic features, pap stain, ultrafast pap is a pap stain, so the keratin looks, like orange phthalic, the best for keratin. Also, ultrafast is excellent for pigments, like whether it's melanin, approved for melanoma, or hemosiderin. Also very good for cell junctions. So it's like double standards. You diff quick for certain features, ultrafast PAP from a different set of features. So when you have both, then you become very powerful. So I'm going to show you really exotic cases, like this 2007 72-year-old doctor. has a breast nodule. On diff quick stain, you say, oh, looks like a fat necrosis. Let me do I would say this macrophage, of course. Let me do ultra fast pap stain and no low power. Oh my God, there's tissue fragments, and then go to high power. They're cohesive and have malignant nuclei. So it's a cancer, it's carcinoma. For some reason, this carcinoma make a lot of lipid. That's why ultra-fast pap really saved me. And later on, the patient has surgery at Cornell, and here's a recut. It's you could see, of course, in tissue section, you don't know how fragile they are, and nobody will do a lipid stain, but and that's a in situ part, and this is infiltrative part. It's a ductal carcinoma. So ultra-fast pap stain me from making tell the patient wrong diagnosis. Can you imagine if I tell the patient, oh, you have it, don't worry about it, it's fat necrosis, and then turned out to be a carcinoma. So ultra-fast pap is very important for breast, not so important for thyroid. So another very exciting case we wrote, shared in a publication, it's a 62-year-old Asian Chinese woman at Belleville FNA clinic. So the fellow did, she had a rapidly enlarging breast nodule. The fellow did the biopsy, did diff quick look weird, has a lot of mesenchymal tissue, and inside, when you go to high power, there's a tumor cell look like a rhabdoid tumor cell. So on ultra fast pap stain, it's even more weird. The tumor cells are brown color, and some of them are two-tone. One has blue on the outside and brown in the inside. And look at how ugly the nucleus is. It's triangular shape, red, and definitely malignant. So it was signed out as malignant neoplasm favor metaplastic breast carcinoma. Of course, a patient has surgery at Bellevue. And then this is a recut. It shows there this primitive component, and then the rhabdoid component. And I was extremely curious because I was an electron microscopist for 9 years before medical school. And then first time when was joining Cornell, told Dr. Knowles I want to do electron microscopy of tumor cases. He said, fine. So I did a lot of EM. And then, so I decided to investigate why the brown pigment. I cut a piece of tumor out from paraffin and processed for EM. And then, lo and behold, the tumor cell said sarcomere. Then say, oh my God. So ultra-fast pap stain, the skeletal muscle looked like skeletal muscle, it's brown color. So it was a lot of fun in this, you see. And this also cytokeratin positive, so it's a metaplastic carcinoma. and we share this. And this is another pelvic patient. He presented with the tongue. He couldn't close his mouth. And the core biopsy was unsuccessful because bleeding too much. So they request a resident fellow to did the FNA. And there, it makes smear, and not too many cells come out. It was very bloody. But you can see we have tumor cells. It's like 2-3 times RBC. And then ultrafast PET stain has promonuclear clear cytoplasm. And so it really looked like renal cell carcinoma. And turned out patient had the kidney removed, but it's been so long he totally forgot about it. So renal cell carcinoma, clear cell. And then they, because they had trouble close his mouth, so excision of the tumor, and the recut looked like, clear cell renal cell carcinoma. Cells don't lie. And here's a patient from Africa, because Belleville Hospital accept patient, charity patient. So he had this until he gets so advanced, so his relatives tell him come to Belleville Hospital. So he show up at Belleville Hospital, and then the resident did the FNA and make smear. And then when I look at the smear, I say, there's a mesenchymal tissue, but how come there's single cells? I have no idea what's going on. How come? And then when I tried to look at the thick tissue fragment, I couldn't see through. So ultrafast PET stain will shed some light. And then I say, oh, wonderful. It's a cartilage. It's a cartilage with big, ugly nucleus. Therefore, it's chondrosarcoma. It just shows when you have two stains complement each other, it could become very powerful. If I did not do any PET stain, I won't be able to diagnose. It turned out the patient did not have any surgery, because once it got the diagnosis, you have to take half of his face out. So that's there's no tissue follow. And also, see, like this case, there's some single cells on Diff-Quick, could be lymphocytes, but on ultrafast, but on Diff-Quick stain, it's not, because I see a lot of single cells, but there's no lymphoid tangle, there's no lymphogranule body, so cannot be lymphocytes. And how, with Golgi apparatus plasma cell, so it become very easy. It's plasma cell myeloma. So Diff-Quick is very useful for plasma cell. And then thyroid, and this is Park Avenue Radiology, ultrasound guided FNA. And Diff-Quick is the most useful thing in thyroid, because it shows the abundant colloid, because most thyroid nodule colloid nodule, and then Diff-Quick stays the best for demonstrate colloid nodule. So you have abundant thin colloid, some thick colloid, and flashes of epithelium. And that ultrafast PET is perfectly benign. They're round, even. So diagnosis colloid nodule. If it's very big, you go nodule border. And then on the other extreme, lots of cells, but you cannot see papilla because they're flattened on the slide, dry. So ultrafast PET saying the papilla will rise up and then like rising balloon, and then shows the papilla really well. And then you have often any nuclei. It's so easy, papillomastoid carcinoma. Uh, and then back in 2001, I shared my finding thyroid. And then, and they like it so much, they make it into cover. The essence is when you have small follicles, ultrafast PET stain could tell whether nuclear feature of papillocarcinoma or follicular. And later on in cancer cytopathology, I say this rehydrated nuclei look like grapes, watery grapes. So at the low power, I could tell the top is cherries, the middle is grapes, the bottom is mixed. And then the same area at high power to oil immersion, you see the difference. So the artifact of often watery grapes is not because the artifact is intrinsic to the tumor. And then several gland, one of the most difficult is to tell adenocystic carcinoma for cylindromas pleomorphic adenoma. And then with ultrafast PET stain, you could tell adenoma has abundant cytoplasm, and adenocystic carcinoma had no cytoplasm. But under electron microscopy, there's scanty cytoplasm, but you cannot resolve it with light microscope. So I use this to help me. And then I share this finding there because Dr. Weissman was my boss, and he used to say, this could be cylindromatous tumor, this could be adenoma, or could be carcinoma, and which is useless to the surgeons. So another case is a very big left submandibular nodule for 2 years, a Lennox radiology patient. And then a lot of cells, but I have no idea what it is. Doesn't look like, it's really weird looking. And then go to high power diff quick, I see a lot of negative images. The nuclei are oval, weird. And then when I come back, I did ultrafast PET. And then I immediately saw cell junction. So the cell junction are interwoven cell junction. And since I did EM before, and I know what immuno should order. I should order neuroendocrine immuno. And then sure enough, it's positive. So it's carotid body paraganglioma because it gets so big, it presents as a submandibular nodule. So sinus spindle cell neoplasm consistent with carotid body paraganglioma. The point is you use immunostain selectively instead of like a shotgun approach, throwing everything. You already have a hypothesis, you just order immunostain to confirm your diagnosis. And here's a recut of the tumors, because I give a definitive diagnosis. So the surgeon could first, stop blood flow, clot it, and then very neatly remove the entire tumor. And you wonder, how come histology is so different from cytology? Let me show you. High power 40x of this paraganglioma. And then this is cytology, or the 40x. Because in paraffin section, you fix the entire tumor. They don't get chance to separate by smearing. We make a beautiful Swedish style smear. The cells in the edge are separate, so reveal its cell junctions. So you have the clue of what kind of spindle cell it is. So basically, it's the same thing, different artifact. So we share our finding in diagnostic cytopathology. And lymph node, it's very good for metastatic carcinoma, and difficult to tell, but the ultrafast PET stain to tell what kind of carcinoma. On the left, it's squamous because it has keratin. On the right is undifferentiated carcinoma, consistent nasopharyngeal carcinoma, very delicate cytoplasm, oval, vesicular nucleoli, prominent nucleoli. And then the treatment is totally different. And there are a lot of patients with lymph node. But if I have a young person, and then the sonographer told me the Highland is 0.5, because I told, and I could start writing my report, it's reactive lymph node, because this lymph node is grossly normal with a beautiful Highland. So, and patients young. And then that's how reactive polymorphous nuclear lymphocytes. But that's why I say always use clinical and then radiological, the Highland. I refuse to look at the slide without first knowing the 3 measurement of the lymph node. And this African American woman present with lymph node. She looked healthy, but she has a fattened lymph node with fattened Highland. So the first pass already has something look like granuloma. And the background is very clean. There's no necrosis. So cyto is sarcoidosis. And then this histology of sarcoidosis, as you all learn from second year medical school, sarcoid, non-necrotizing granuloma. If it's TB, it'll be, the background will be very caseous, very necrosis. So it's totally different. You have to truly believe that in the mechanism, pathogenesis to make such a diagnosis. Everything you learned so far, pathology works. And then AIDS, pelvic patient, AIDS patient, raw lymphoma. And then the diff quick stain saw a lot of new macrophages with negative images. So it's MAI, lymphadenitis. So after sign up course, you do a cell block and then AFB stain for teaching purpose. And it's confirmed. So the beauty of Diff-Quick. And then this patient, young person with abnormal lymph node, right away you look at, there's some big cells. And then ultra-fast PET saying look for Hodgkin cells, Reservoir cells. So everything fits, young, man, and abnormal. So it's Hodgkin, and then do immunostain on cytology, CD30. So it's Hodgkin lymphoma, and it's confirmed at Memorial Sloan Kettering. And Burkitt's lymphoma is cytopathologist's best friend, because I used to work at Bellevue Hospital. We had a lot of Burkitt lymphoma from AIDS patients. And then if we have to wait for, and it's very easy, characteristic, medium-sized lymphocyte with light blue cytoplasm and lipid droplets. That's so, it's ultra-fast PET. So you could right away diagnose Burkitt lymphoma. If you wait for all this special study, if it's Friday, by Monday, you'll receive a CSF, says metastatic Burkitt lymphoma. So this is not a case a year ago at the Lennox-Hill Radiology. And the site of prior follicular lymphoma, grade 3A/3. But she never had chemo, because the doctor said there's only one lymph node and she's cured. And at the site, she had abnormal lymph node. And then when I look at, there's some scattered big cells. So it's, and there are ultra-fast PET, you have follicles with big cells. So it's recurrent lymphoma. Whatever she had is coming back at the same time. However, flow cytometry is negative. So should I trust flow cytometry, or should I trust clinical judgment and the cells? I decide to trust cells and clinical judgment. So I report recurrent follicular lymphoma, the exact same. And then patient has surgery here. His follicles effaced lymph node. And flow cytometry says CD10 positive loss that with very dim capillary restriction. So it's recurrent lymphoma. Abnormal lymph node, but no pathology in the sample, no granuloma, then you must do flow cytometry to rule out non-Hodgkin lymphoma. It's very, very difficult to rule out low-grade lymphoma based on cytology alone. Very, very difficult. Even I could diagnose non-Hodgkin lymphoma on cytology, I still have to do flow, because this way you know exactly what type and what kind of chemotherapy to use. So flow cytometry is very, very important. Like this patient, long-standing growing lymph node, abnormal, very fat, high lymph. And then once I see this, I said, flow cytometry, there's no granuloma. And then also I did ultra-fast PET stain, and I processed back in the SAR-10. And then flow cytometry a day later shows monoclonal CD10 positive B cell. So follicular lymphoma low grade. And it's really very difficult to.
No, it's liver.
Hi. So it's very difficult to tell. And flow cytometry is crucial. In retrospect, once I know lymphoma, I check, oh, it's small cleaved cells. And now we're going to do CT scan. CT scan we used to do it Park Avenue Radiology. All kinds of CT scan using 25 gauge spinal needle. And this is a Bellevue case. A Chinese man complained of progressive short of breath. And then this big mediastinal mass come out, the cells looks like epithelial neoplasm. And then at this setting, it has to be germ cell tumor. And Harvard was inconclusive, so they did that for right away. Patient were had frozen section, and they did all kinds of immuno. And then it was signed as atypical seminoma. We also published it. And after chemo, the patient fully recovered. And another case is a Bellevue patient, smoker with mediastinal mass and lung mass. Clinical impressions, lung cancer with high metastasis. So they did the lung FNA, and then immediately, very striking and difficult, you have this metachromatic substance, and they're very slimy. Like it actually, I saw this before back in 1993 at Cornell, and Dr. Tao told me that the clue, cytological clue, it's the substance, slimy substance. It's a clue for yolk sac, baby yolk sac. So I told the clinician check for alpha-fetoprotein. They did not believe it. They said I was crazy. And then here's alpha-fetoprotein after treatment. And then it worked very well. And then later on, they did the residual tumor, did the resection, and surgical pathologists confirmed the diagnosis. So we share this unusual cell tumor at the diagnostic cytopathology. Here's a big gastric mass and liver metastasis. Have very bland spindle cells. And it's very important in this case to do cell block and then immunostain to confirm GIST. Here's the ultrasound guide liver FNA. Now let's talk about liver. The basic of liver aspiration. Back in 2004, we published a paper, Share Experience in Modern Pathology. What I discovered is once I do ultrafast PET, if it's benign and malignant, it's totally different. And benign liver has very rigid. I couldn't smear no matter how hard I try. but when it's malignant liver, very easy to smear. And the pathologic basis is because normal liver has reticulum fiber layer by layer. So no matter how hard you try to smear, you fail. They're very rigid. But once it becomes malignant, the reticulum fiber is markedly reduced. So therefore, you could make a beautiful smear. And this is a very helpful clue. No high tech, just use, because liver specialists also use reticulum fiber stain. And so, and second paper is initially the classic hepatocellular carcinoma was described by Dr. Elsie Tao. And then I later had other type, one with microtrabecular, one's microasthena, positive, but there's no trabecular pattern. So share this in that's classic HCC with endothelial lining, microtrabecular low endothelial lining, and then microasthena type, no trabecular lining. See, benign liver aspirate, you have abundant reticulum fiber, therefore you cannot make a smear. Here's an abdominal scar, pain, multiple liver. This is a Bellevue case, diff quick pap, and the diagnosis was based on cell block. It's angiosarcoma. And pancreas, two major types, one salt and pepper single cells, pancreatic neuroendocrine tumor, that there's ductal carcinoma with various ductal flat sheet, the nuclear size variation, ductal carcinoma. And then a case that growth pathology, it's like this. See, radiologist growth pathology. And in this case, you have serous fluid and cell block, and it's serous microcystic adenoma pancreas. So incidental finding, a young Indian woman, and it has this beautiful Chinese character ligament. It's solid pseudo-papillary neoplasm of pancreas. Ductal dilatation and mucus oozing from impure vata. And this is classic presentation of IPMI. And here's the cytology, histology. Here's a real case. A friend's father had a mesenteric mass. CT guided FNA, I was on site. And then the cells don't lie. This looked like well-defined neuroendocrine. So it's a carcinoid. And then when surgery shows actually the nodules are lymph node with metastatic carcinoid, patient doing great. And this colon, because colonoscopy was non-diagnostic, show area narrowing. That's why CT guided FNA was performed. And it shows a lot of mucin. Inside the mucin has signet ring cells. Cell block shows mucin coming. cytokeratin 20 positive 7. So it's make diagnosis colonic adenocarcinoma. Kidney cord, actually, this is my brother's father-in-law. He was scheduled to go back to Peking on Monday, but a week before, the MRI shows kidney nodule. So he called me. I said, "Oh, no problem. Thursday, Dr. Messina, we will take care." So they came in. Dr. Messina did one pass using this spinal needle percutaneously, and I made 2 smears, one different. So it's very classic in the setting. It's renal cell carcinoma. So he had a nephrectomy, and Robert Johnson has a New Brunswick. It's a clear cell carcinoma. And also at the pelvis, it's very difficult to tell initially, but has this tadpole-shaped cells, circumference cells. And then low power shows papilla with scattered circumference cells. So it's papillary urothelial carcinoma. And pelvic mass, 60-year-old woman with right side hydronephrosis. This is 3 months before I left for Cornell. And I did this pelvic mass. And then I see diff quick, your best friend red blood cell. It's, even though there are a lot of epithelium, the red blood cells one times is benign epithelium. And then ultrafast pap stain has this very organized architecture. So it's endometriosis. And the weekend conference before I left, they were presenting a case of this is a follow-up, polypoid endometriosis. And here's a young woman with right side swelling, so crucial leg vein. They rule out DVB, but unresponsive. So finally did FNA. Difficult shows mesenchymal tissue, so the mesenchymal tumor with big nucleus. See, so it's a high-grade sarcoma. I don't know what high-grade sarcoma. Patient has surgery at NYU. It shows it's an angiosarcoma arising from external iliac vein. So cell block and immunostain flow cytometry, those are very important part. Cell block already mentioned last time. Here's a resident's wife had 3 weeks after giving birth developed abdominal pain, and CT scan shows the spleen has several nodules. Everything else is fine. So CT guided FNA and some plant cells, but I really don't know what it is. Cell block shows this thing is diagnostic with co-expression of CD68 factor 8. It's a diagnostic liposcell angioma of the spleen. Such fancy diagnosis would never be possible without cell block and immunostain. So we shared diagnostic. So here the above are my presentation, and I'm ready for questions. Any questions?
Hi, yeah, I have a question. So, as far as I know, like now the FNA is not performed for kidney masses. Am I correct?
You're correct. That was 1997 in the Wild Wild West. But in some other medical center, they doing quite a bit of kidney FNA. There's no reason. It's all what you used to, but in potential, as long as you have good technique, fine needle, you could do any organ, any side. But whether or not we used to have a lot of kidney FNA in 1990s, and then the referral stopped. But as I understand, something at the Johns Hopkins, they're still doing kidney FNA. The most important thing is to have good technique. Don't did 1 or 2 pass and you're done. And because when Park Avenue Radiology started doing FNA, I told them we have to do where outpatient, you don't have a nurse, we have to absolutely no incident. We have to do it very precise, very quick, going really quick, 1 or 2 pass, get the cells out. And we never had any complications. And Dr. Messina was very talented in getting the sample. And everything's technique. If you're in the best hands, then you could do anything. If the aspirator is not so good, and then you keep poking, getting all kinds of things. What I present was my personal experience. Okay.
Is that like they stopped doing the FNAs because of the concern for the complications or a seeding of the tumor, like into the retroperitoneum or whatever?
They stopped doing it because they just like they just stopped. Just like breast FNA, I did so many breast FNA, and then now they stopped. They use needle core biopsy. Did and it's because the insurance will pay a lot more to the radiologist if you do core reimbursement, over $1,000 per core. For breast FNA, they only could bill $500. And they used to say, oh, your cytopathology make more money. We did all of this, so we only get paid. But if they do core, they could bill $1,050. So once they have incentive to do core biopsy. But we never had any complications. And I know a lot of big medical centers still doing kidney FNA. And it all depending, this is America, but listen, in Europe, in Asia, in Australia, they don't have American payer system. They still, breast FNA is still the main thing. They use breast FNA to triage, if the breast FNA is inconclusive, then do a core. But breast FNA is enough to do the next step. They trust cells. In Australia, everything's breast FNA. It's, whatever they decide, it's out of my control. But my personal experience is, if you have good technique, good needle, it's really wonderful for the patient, and patient know right away. Of course, certain you cannot tell by cytology, and then you go the next step. I used to tell patients, well, the breast FNA, maybe it's nothing, but I think it's best to do a core because, I hope I'm wrong. Better safe than sorry. And you just to tell them.
Thank you, Dr. Yang.
Okay. Here it is. Bye.
Thank you, Dr. Yang.
Okay. Bye.
Goodbye.